Hello guys, welcome back to the channel. Thank you guys for showing so much love. So here I am presenting the 20th notebook. So this will include glimpse of high topics, high images, and also not only this, since you guys have been requesting anatomy a lot, so in this video I have covered the upper limb part of the anatomy that we will be doing towards the end. So now let's get started with the high revision, some random topics part 1. Okay, so let's get started. First of all, the first most important thing that gets frequently repeated is your vacutainers ka concept. Okay, so what is the color coding of the vacutainers and what are the things you keep there? Okay, that is very important. So first of all, you have red color vacutainer that does not have anticoagulant, guys. Be very sure red has no anticoagulant. Okay, and it is used normally very commonly, which you see in your lab daily, day to day, in your clinics ward round, LFT, RFT, serum electrolyte, lipid profile. Then coming on to the gray wala, that is this contain an enzyme, okay, sodium fluoride. Okay, this is an anticoagulant that inhibits the enzyme enolase. Okay, and this is used for, this gray wala is used for glucose ka estimation. This is very important. Then coming on to the next commonly used one, that is purple one. Okay, so this purple one contains EDTA, okay, ethylene diamine tetraacetic acid, and this is used for means blood wala things, that is complete blood count, erythrocyte sedimentation rate, and CRP. Then coming to the blue one, okay, this blue contains 3.2 to 3.8% sodium citrate, and this is used for, this blue is used for coagulation study. Okay, remember blue for bleeding profile. Okay, coagulation time, bleeding time, clotting time. Okay, blue for bleeding profile, remember like this. Then coming on to the green one, okay, so this green one contains heparin, okay, and is used for bone marrow studies. Okay, this is about the green one. Then coming on to the yellow one, okay, this yellow one contains citrate and is used for blood culture. Okay, then your pink one, this pink one is very less commonly found, and this is basically used for blood banking. I have hardly seen in my labs this pink one getting used. Instead of that, red one is commonly available, that is used, but for blood grouping, blood typing, ABO, the pink one is preferred. Okay, and this contains potassium EDTA. This is again a important thing, so one of this can be repeated. So this is a important topic you must know. Now moving on to the next one, that is your mosquitoes. Okay, so about the 4 mosquitoes that you commonly see, one is the Anopheles, Aedes, Culex, and the Mansonia. So this Anopheles mosquito is the sophisticated mosquito, remember AC. Okay, so people who have AC in their house, they are sophisticated. C means it breeds in clean water. Okay, and remember this sophisticated people, they have a means swimming pool in their room, in their house. Okay, that is boat shaped eggs are there with lateral floats, and this Anopheles, they have spotted wings, you can see the image. Okay, okay, this larva, they can fly up to 3 to 5 kilometers, this mosquitoes, and they rest parallel, and they do not have any siphon tube. Anopheles, no siphon tube, you can see name only says no. Okay, and Anopheles transmit your malaria. Now coming on to your Aedes one. Okay, so this Aedes mosquito, 5-letter Aedes, 5-letter tiger. Okay, so this Aedes mosquito is tiger mosquito. This Aedes breeds in artificial water. Okay, this Aedes is this eggs are single cigar shaped eggs. Okay guys, it looks like this single cigar shaped eggs. Okay, and the shape, this has a hunchback posture. This both Aedes and Culex, both of them has a hunchback posture. This is important. Then now rest at an angle to the water surface, and siphon tube are present in both Aedes and Culex. Again important. So what are the diseases that this Aedes transmit? Okay, Aedes, yellow fever, Zika virus, dengue. Okay, so remember like this, AEYDEZ, Aedes. Okay, Y for yellow fever, D for dengue, and D for dengue, Z for Zika, and C for chikungunya. You can remember like this. Then coming on to the Culex. Okay, remember CD. D is for, it is breeds in dirty water. X are small clusters. Okay, and for this it can only fly up to 100 meters. Okay, this can go up to 11 kilometers, Culex. Okay, and here this transmits your lymphatic filariasis, Japanese encephalitis, and your West Nile fever, which is not so important. Okay, so this is about your mosquito. So we will reinforces what we have read, guys. Now try to recall with me. Anopheles transmits malaria. Aedes, your dengue, chikungunya, yellow fever, and the Zika virus. Culex, Japanese encephalitis, and the filariasis. Okay. Then Mansonia filariasis. Okay, this is like less commonly but can be found. Now Anopheles, guys, AC, that is clean water. Okay, what that should be stagnant water, in stored water basically malaria breeds. Aedes, that is your artificial container or artificially stored water. Culex, CD, that is your dirty or polluted water. Then Mansonia, basically in large water body where you see aquatic plants. Now coming on to the egg. The Anopheles ka eggs, okay, they are boat shaped with the presence of lateral floats, very important. Okay, Aedes ka eggs are cigar shaped. Then Culex ka eggs, they are cluster. Okay, C for Culex, C for cluster, and they are present in rafts. Okay, then coming on to Mansonia. Mansonia are also in cluster, and but this Mansonia are star shaped. Then coming to the larva, this Anopheles ka larva, they are surface feeder because they don't have a siphon tube, so they need to come to the surface. So this is a surface feeder. Aedes and A both have a siphon tube, so both of them are your bottom feeders. Okay, and this Mansonia is attached to the roots, also has a siphon tube attached. Then coming on to the biting time, this Anopheles mosquito bite either in the morning or in the means after the sunset. So okay, that is dawn and the dusk. Aedes the day. Aedes is throughout the day, guys. Okay, Aedes is daytime, that is 2 hours after sunrise and 2 hours before the sunset, that is daytime. Then Culex, that is midnight time. And your Mansonia, okay, that is your evening time, Samka time. Mansonia, that is Samka time, that is your evening time. Then coming on to the flight, Anopheles can fly up to 2 to 3 kilometer. Aedes I said only very less, that is 100 to 200 meter. This Culex can go up to 10 to 11 kilometer, that is important. Now coming on to the resting position. Okay, this Culex wala mosquito, they have a hunchback appearance. You can see how this hunchback appears like this, guys. Okay, then parallel to the surface is your Aedes, and Anopheles is inclined position. Then coming on to the special feature, guys, this they have a spots on wing, important. Here they have stripes, hence Aedes is also known as tiger mosquito. Anopheles was also known as sophisticated mosquito, and your Culex was known as your nuisance mosquito. That is important. Culex again done. So this was all about the mosquitoes that you need to know. Now moving on to the next highly important topic, that is your topic of CD marker, which is very frequently repeated in your exam. Okay, so reading the topic of CD marker. Okay, see, when we do the CD markers, first of all you have cytotoxic T cell, matlab killer cells. That is CD8 wala cell is your killer cell. Then most sensitive marker of RS cell. We know that for RS cell we have two marker. One is the CD15 and one is the CD30. So this CD30 is the most sensitive marker. If we talk about the marker, okay, what is RS cell? This is basically your Reed-Steinberg cells that you see in your lymphoma ke cases. Okay, Epstein-Barr virus, which included EBNA wala things. Okay, CD21, CR2 receptor attacks. So this is all the things that can be asked in your exam. CD30 and CD15. Then coming to the monocyte ka marker, that is your 14 and 60. Sorry, that is your 16 and 64 is your monocyte ka marker. Then your helper T cell. We know they are cytotoxic and helper. Helper means CD4 and cytotoxic means CD8. Then coming to your cytotoxic T cell, already done, that is your CD8. Then Langerhans cell histiocytosis, LCH, you might have already heard, guys. Okay, that is your CD1A, CD207. This is also known as Langerhans, that which shows the presence of tennis racket, if you can recall, guys. Okay, and this has on electron microscopy Burbeck granules are seen. Again a PYQ that can be repeated in your exam. Then coming to the granulosa cell tumor, a tumor of the ovary, guys, which shows the presence of coffee bean nuclei in your granulosa. So the marker is CD99. Then Ewing sarcoma, guys. Okay, Ewing sarcoma, the marker is CD99 or MIG2. This Ewing sarcoma, if you recall my video on ortho wala, so can you recall what is the location of this Ewing sarcoma? So this is a tumor of the diaphysis. This is a small round blue cell tumor, this Ewing sarcoma. And what was the mutation, guys? Wings fly, that is EWS FLI1. And what was the gene in translocation, guys? Even E for 11, that is translocation 1122. You wear on 11 and wings help you fly to the double height. That is 11 2 is 22. That is translocation 1122. Then coming to the marker of Burkitt's lymphoma, guys, that is CD19 B cell ka marker, CD20 B cell ka marker, and Ki67, which is a proliferation marker basically. Okay, now coming on to the marker of apoptosis, guys. We have CD95, that is the marker of apoptosis. Also we had annexin 5, that also you need to remember. And annexin A1 was there in hairy cell leukemia. Then CD markers for selectin, guys. We had CD62. We had three type of selectin. What? PEL, P selectin, E selectin, L selectin, guys. So they may ask you which one of the following is not a selectin. Then coming to the beta 2 integrin, guys. Okay, so we have CD11, CD18, guys. So this is present in your inflammation wala chapter, very important. Then PCAM1, okay. So basically when transmigration happens, that is your CD31, which helps you in transmigration. Then natural killer cell, that is your CD16 and CD56, guys. Okay, and see this monocyte was 14 and 64 only, guys. Okay, not 16 and 64. I think they printed it wrong. It's 14 64, I'm sure. Okay, then coming to your megakaryocyte, means platelet ka marker, guys. That is CD41, CD42 and CD61 is your platelet ka marker. Then co-stimulatory molecule. This is very important. That is your CD28 of T cells, guys. Okay, 28, 20 T. Okay, remember like this, T for 20, 28. Okay, that is your T cell CD28. For B cell, it's your CD40 co-stimulatory. Then pan B cell, pan T cell. Pan B cell is CD19. Pan T cell is your CD3. Again, very very important. Then CD1117, also known as, guys, C-kit. Okay, so when you go to play, you need to play a game, you need a kit. Okay, so G for gist, M for melanoma, okay, S for seminoma. Okay, so this are cutaneous mastocytosis. All of them shows the presence of c-kit mutation. Then CD34 is a marker of stem cell, basically proliferation ka marker, matlab basically the cells hematopoietic stem cell. So gist also shows, endothelial cells also shows, blast also shows CD34 positive. Then gist is positive for, you can see both gist comes at both of the places, guys, CD34, so this is positive for both. Then coming to the your lymphoma wala thing, guys, marginal zone, so both are at the extremities, so we'll put both negative, guys, CD5 negative, CD23 negative. Then coming on to your mental cell ka. Okay, and what is the translocation in marginal zone, guys? Translocation 11 18, both are at the margin. I think you remember the concept. We had translocation 11 14 18, 11 and 14, okay, was your mental cell ka lymphoma. Okay, 14 and 18 friends, 14 follicular, that is 14 and 18 was for follicular, and 11 and 18 was for and 11 and 18 was for marginal, and like translocation 8 and 14, that was for Burkitt. Then myeloid lineage, guys, okay, that is CD13 and CD33. See, this we have already done. CD molecule for Epstein-Barr virus entry, CD21 CR2. Then your popcorn cells, guys, okay, that is non-lymphocyte predominant Hodgkin's lymphoma. So that was non-lymphocyte predominant, so it was CD20, CD45 and EMA positive. Again important. CD markers associated with PNH, guys, okay, PNH is paroxysmal nocturnal hemoglobinuria. So here we had two factors, that is decay accelerating factor and MIRL. MIRL means membrane inhibitor of reactive lysis. So you need to know which is CD55, which is CD59. So D plus A means 4 plus 1 5. So this CD55 is your DAF, and this membrane inhibitor of reactive lysis is your CD59. This is again very important, guys. This can lead to thrombosis also. Then markers of your hairy cell leukemia. So this hairy cell leukemia, CD11C, CD and annexin A1 is also a marker, guys. Okay, so these are the markers of your hairy cell leukemia. Then CALM, the common lymphocyte antigen, guys, that is your CD10. Okay, so CD3 was a pan T cell marker, CD19 pan B cell marker, CD7 is a common leukocyte antigen. Then marker for acute graft rejection, that is your CD4D. Be very careful, guys, that is D. Okay, they have discarded it. Okay, discarded, remember like this is not discarded, just remember, guys, discarded. Then plasma cell marker, guys, okay, so plasma cell where you see the cartwheel wala chromatin wala thing, eccentric nuclei, that is CD38, CD138 positive. Then CD30 positive tumor, if they ask you, one is the PEL, that is primary fusion lymphoma. Then you have ALCL, guys, okay, where you see kidney or any form shaped cells. Then you have Hodgkin's lymphoma and your embryonal carcinoma. So this was all about the CD markers that you need to know, guys, okay. So this is basically the summary of your CD markers ka table that you must revise before going to the exam. Now moving on to the important genes wala thing, okay, that is very volatile thing that you need to know. Okay, so first of all, P53. So this P53 is located on chromosome 17p13. Okay, and this is mutated. This is mutated in your Lee-Frommany syndrome. Again, very important, guys. Okay, then coming on to your retinoblastoma gene, that is located on 13q14, and this is found in retinoblastoma or osteosarcoma. Again, important. Then NF1, guys, that is neurofibromin. Okay, if you count neurofibromatosis, that is, guys, 17 letter, that is chromosome 17. NF2 22, okay, that is mismatch the mnemonic, guys. Okay, that is multiple inherited schwannoma, bilateral acoustic neuroma, schwannoma, that is your NF2, guys. Okay, and here it is protein is Merlin. Then coming on to BRCA1, BRCA1 and BRCA2. So this BRCA1 is located on chromosome 17 and BRCA2 on 13, and both of them are used in breast cancer. Okay, so this BRCA1 in breast and ovarian cancer, BRCA2 in your male breast cancer, in your prostate cancer. Okay, that is BRCA2. Then Wilms tumor 1 and 2, that is 11p13 and 11p15, guys. Okay, so Wilms tumor, like we have syndromes like Vagar syndrome, Danish-Dash syndrome. Okay, so this all the things are important, guys. Question Bachmann-Whitman syndrome, where you have hypertrophy of limbs, omphalocele. So this all the things are very important that you need to know. Then coming to your P10, name only says this is present on chromosome 10. Okay, then what are the tumor that you see? See, make P into a B. That is P ka B, breast. T means thyroid and EN means endometrium, guys. I think this becomes very easy now. Then VHL gene, guys. Okay, this is located on chromosome number 3, guys. And what does this cause, guys? This can cause ciliary renal cell carcinoma, cerebellar hemangioblastoma, pheochromocytoma, pancreatic cyst, angioblastoma, guys. This was a PYQ, guys. This is very frequently repeated question, guys. Then APC gene, which causes, guys, adenomatous polyposis coli gene. Okay, FAP wala syndrome, that is chromosome 5. Okay, so this can cause FAP and your adenocarcinoma colon. So this was about your gene wala thing. Now coming to some PSM wala thing, guys. Okay, one question is very much expected, and this notes is taken from Telegram. So thanks to her. Okay, now moving on to this one, guys, that is your toxin and food product and how to prevent it. First of all, neuroletharism. So this is due to the beta oxylamine intake. Okay, this is the toxin, and this is in a dal known as Lathyrus sativus. Okay, that is your kesari dal. And how can you prevent it? By washing it. Okay, that is steeping or parboiling or adding a vitamin C in the diet. Then coming to the endemic ascites. So this is present in the crotalaria seeds, that is pyrrolizidine, and the food product is millet. And how can you prevent it? That is by filtration or the sieving. Then epidemic drowsy. Okay, this is due to the Arzimon mexicana. The seeds of Arzimon mexicana, they resemble to the mustard oil seed. So they try to adulterate it. That is, we need to pre-test before the consumption. Then aflatoxins, guys, that is stored groundnut, guys. This you have already heard. That is, this can cause hepatocellular carcinoma wala thing. So groundnut is the most common food product, guys, as aflatoxin, due to aspergillus flavus. So you need to increase the ventilation, decrease the humidity. Then ergot, guys. Okay, so this ergot is obtained from a fungus known as the Claviceps purpurea, and this is present in jawar rice sorghum. So prevention, that is float in 20% or salt solution. So this was about the toxin and the food product. One of this can be repeated, guys. Okay, now coming on to some visual wonder from your dermat point of view, guys. That is your central lesion, guys. Okay, so basically the question may be asked, and where do you see it? So we need to see the central, guys. Okay, here you see the central clearing, here you see central crusting, and here you see central scarring. Okay, so this central clearing is seen in your tinea infection. Okay, this central crusting is seen in your cutaneous leishmaniasis का reaction, crusting वाला thing. And this your scarring is seen in your lupus vulgaris, that is scarring. Okay, clear tinea. Okay, and crusting is for cutaneous leishmaniasis. Okay, that is important, guys. That is about your dermat revision. Now moving on to some more important things, guys. Okay, so this PDF has been taken from the Preeti ma'am telegram group, so this is very good for revision, so I thought to use it, guys. Okay, so thanks to her for making such amazing notes. So see, first of all, this is the karyotype. Okay, so what do you see here, guys? Okay, this normally what happens, this chromosome number 21 is the shortest chromosome, and this karyotyping you perform it at the metaphase. Okay, by arresting it with the help of colchicine, and most common staining method is the G banding staining method, guys. Okay, now coming on to the bar body. This bar body is an inactivated X chromosome, and this hypothesis is known as your Lyon's hypothesis. This is a PYQ that is frequently repeated in the exam. So there is inactivation of the chromosome, guys. Okay, so inactivation of the X chromosome, guys, takes place at the day 5.5. Not so important. This inactivated X chromosome is only referred to as your bar body. So now someone asks you how many bar bodies are there in a girl child. Okay, female child, that is number of X chromosome, 2 X chromosome minus 1. That is in a girl child. Boy, that would be 0, because only 1 X chromosome is there, and that is also inactivated. Okay, so you can see this is a few examples to calculate the bar body, guys. You can have a look at it. Now coming on to the most important thing, guys, that is your autosomal dominant recessive, X-linked dominant recessive. How to remember it, guys? Okay, so autosomal dominant, guys, see, there is a very simple rule to identify whether it is dominant recessive or see, first of all, guys, I'll give you a rule, guys. First of all, check the gender affected if you have a pedigree chart. Okay, then the next is check if generations are skipped or every generation is involved. Generation is skipped or involved. If all generation is skipped or involved. See, how do you identify it, guys? If there is a particular predisposing towards a gender, means this is most likely X-linked. If they are equal involvement, that is your autosomal wala thing. Now, when you think it's autosomal, now the confusion starts whether it is dominant or recessive. If all the generation, someone is involved in all the generation, first generation, second generation. So, if someone is involved in each generation, that is your dominant. If one of the generation, no one is involved, that is your recessive wala thing. Because for recessive, both of them must come there, guys, to be there. But for dominant, if both are there, then also it can express, or also if it is heterozygous, then also it can express. So that is important, that you need to know. See, now we'll talk about this one, guys. Okay, suppose someone gives you C, so we see males are also affected, guys, females are also affected, means this is a case of autosomal ka disorder. Now seeing, guys, whether it is recessive or dominant. See, here in this generation, guys, someone is involved in this generation. If you see, guys, see, this two gave birth to these two bachas. Okay, so do you see, guys, someone is involved, and here also if you see, when these are mating, they are also giving to a woman's affected child. So all the generations are involved. So this is your autosomal dominant disorder, pedigree autosomal dominant. Okay, then coming on to the next one, guys, is your Marfan syndrome. So this Marfan syndrome, basically it is a defect in the fibrillin 1 gene, okay, which is located in your chromosome number 15. Fibrillin 1, F for fibrillin, F for chromosome number 15. Okay, also we had two more things on 15, guys. Can you recall for me? Please put the answer in the comments. We discussed in yesterday's class. Then coming on to M, that is your mitral valve prolapse. A means aortic dissection, that is your most common cause of death. Can you look at the guys fingers, that they are excessively large, guys? Okay, so that is your R for retinal detachment. Marfan, fan is superior, that is superotemporal dislocation. If someone asks you homocystinuria, urine goes down, that is your inferonasal dislocation. F for freely movable joint, that is hypermobile joint. Okay, and this thumb, do you see, normally try to put your thumb, guys. Okay, it won't cross, guys. Okay, try now. Okay, but here it is crossing, so this is known as your Steinberg sign. That is again important. Then A for arachnodactyly, N for 9 feet tall, not like 9 feet, but they are tall, guys. Okay, and just to make the mnemonic, ma'am did it 9. Then S for sternum, there may be pigeon chest scene, and ectopia lentis already done. That is your superior temporal dislocation in your case of Marfan syndrome, fibrillin cut defect. Then coming on to your NF, guys. Okay, NF basically stands for neurofibromatosis. NF1, NF2, which we did now, guys. Okay, so what are the findings in your NF, guys? Okay, the classical hyperpigmented, the macule that you see, guys, it's your cafe eu lat spots. Then you can see the neurofibroma, and in eye you see the Alish nodules, guys. Okay, this was my opthal quiz question, guys. Okay, so this is again a very important thing that is frequently repeated, guys, as a part of triad, as a part of image based question. So this is a neurofibromatosis type 1. If we talk about the type 1 and type 2, guys, we have already talked about this. NF1 located on chromosome 17, 2 on 22. NF1, the gene is neurofibromin. NF2 is Merlin. Okay, what was the mnemonic here? NF2, that is miss me. Two people are missing each other. Miss me. Okay, one of them saying to others. So this NF1 is also known as von Recklinghausen disease, and NF2 is also known as schwannoma. That is bilateral acoustic schwannoma. Now coming on to the next one, that is your autosomal recessive, guys. Okay, so autosomal recessive, guys, first of all the gender will be equally affected, and some generation will be skipped, guys. Okay, so that is about your autosomal recessive wala thing. See, generations are skipped in your autosomal recessive, and there is a complete penetrance. Let's see the example, guys. Suppose, see, this is the first family, first generation. So these are the kids of the first generation. Do you see? Generation skipped. No one is affected in this generation, guys. Do you see, guys? Generations are skipped. So this is a autosomal recessive category. Now coming on to the next important topic, that is alkaptonuria. See, alkaptonuria, if you rearrange the word, that becomes alka becomes scala, that is urine turns black on standing, guys. Okay, this alkaptonuria is a autosomal recessive disorder that is due to the deficiency of your homozentic acid oxidase enzyme. Okay, due to the deficiency of homozentic acid oxidase, guys, this gets accumulated in the urine, so this will turn black on standing in the cartilage and nails, which is known as ochronosis, deposition of homozentic acid in the cartilage. So this can lead to ochronotic joint, ochronotic pigmentation, guys. This is again important. Then coming to the next very high thing, that is a Tay-Sachs disease. Okay, so this Tay-Sachs disease, basically, I think this we all have done in our biochemistry one. So this is basically a revision, guys. That is due to hexaminidase. Okay, this hexaminidase A ka deficiency is your Tay-Sachs disease. So what happens here, guys? T for Tay-Sachs. A means autosomal recessive. Y for young age. Okay, then this is very important. Cherry red spot in the macula, guys. Also, you need to know various other places like blunt retina, commotio retina. Okay, cherry red spots there. Then artery occlusion wala thing, guys. So these are very important thing. A for it's common in aschinosis use. C for here you see, guys, vacuolated solar neurons, guys. Okay. That is again a important findings, guys, because last time they ask you Gaucher's disease, so maybe this time they give you this image. So this is very expected. On electron microscopy you see the onion skinning pattern. Okay, that is again very important. Onion skinning on electron microscopy, and hexosaminidase deficiency already done. And as for onion skinning, then now coming to this zebra bodies, guys. Okay, so this is electron microscopy. Whenever you see black and white, think about electron microscopy. So this is seen in your Niemann-Pick disease, guys. Again important, where you have sphingomyelinase ka deficiency. Okay, this about your Niemann-Pick. Now moving on to the next one, that is Gaucher cell. So this was the question in your last year exam. So this Gaucher cell shows the crumpled tissue paper. C for G, you can remember, like crumpled tissue paper, like as you have crumpled the tissue paper. So, and this is due to glucocerebroside deficiency. Glucocerebrosidase enzyme. So glucocerebroside accumulate. Then coming to the Ehlers-Danlos syndrome, where you have hypermobile skin, guys. See, do you see the elasticity of the skin, guys? The skin looks so elastic. So most common type is the type 3. C common, and type 3 most common. Most dangerous type is the type 4, guys, and least common and most common collagen is the type 3, which gets deposited, guys. Also we know that type 1 collagen is present in bone, guys. One bone, ONE, one coming. Type 2, guys, it's located in your cartilage, guys. You can remember that like this. Then type 3 is in your blood vessels, and your type 4, okay, basically in your floor. Okay, that is your basement membrane, guys. Okay, so this is about your collagen cutting. Then coming to the X-linked recessive category, guys, have a look, guys. What happens? only guys who are getting affected, only the males are getting affected, and the generations are also getting skipped. That is your X-linked recessive disorder. Okay, so this was about your X-linked recessive. Now coming on to the mitochondrial disease. So this mitochondrial disease, basically what happens, mother transmits to all irrespective of the gender of the baby. So that is your mitochondrial disease, guys. Okay, here you see mother is affected, guys. So what happens, each child is affected. Do you see, guys, this child, this child, this child, this child, all the child are affected, guys. Okay, so this is about your mitochondrial disease. So example, you have MELAS, that is mitochondrial encephalopathy, lactic acidosis with stroke like syndrome. Then that is the most common mitochondrial disorder. Then LHON, that is liver hereditary optic neuropathy. Then NARP, that is neurogenic weakness, ataxia, retinitis pigmentosa, not so important, guys. Then CPEO. Okay, so this all are there, you can read it, guys. Now coming on to the next one, that is very frequently repeated. Okay, that is trinucleotide repeat disorder. This I have done in my MTR session, one of them, guys. Okay, so now the time for revision comes. Fragile X syndrome, guys, that is fragile. What are fragile? X are fragile, that is EGG, so you can make into CGG. And here you have a giant gonads, guys, this is important. Then Frederick ataxia. Okay, that is gait, guys. Ataxia means gait, so remember GAAG. Then myotonic dystrophy, so that was Christmas tree cataract wala thing, that is seen in CTG. Then this was about in your non-coding reason, guys. Okay, this was your fragile, Frederick and myotonic. Now coming on to the coding wala sequence. Okay, so coding wala sequence, you have Huntington disease, Kennedy disease, and spinocerebellar. So hunters use a case, that is CAG repeat disorder. Now coming to your fragile X syndrome, guys. Okay, so this fragile X syndrome, okay, this is located, this is the X-linked recessive disorder. So if the repeats are between 15 to 55 to 200, that is known as pre-mutation. Again, very important, guys. And this question was also asked, this is also a PYQ, what is anticipation or the summons paradox. With every generation, guys, severity of the disease increases and disease appears comparatively earlier as compared to the last child. This is again important. Then coming on to features of your fragile X syndrome, guys. Okay, so this fragile X syndrome, we wrote CGG, that is giant gonads, guys, that is macroorchidism. Again, very important, guys. Here you have a long face, then large ears, large mandible, large gonads. And most common cause of mental retardation is your Down syndrome. Second most common cause of mental retardation is your fragile X syndrome. And what is the most common cause of preventable mental retardation? Nowadays mental retardation is not used, guys. That is intellectual deficiency, guys. Okay, that is your congenital hypothyroidism. Again, an important question. Then coming on to the next one, guys. Okay, so this fragile X can lead to means tremor ataxia, so it's not so important, we won't go here, guys. Now coming on to the next one, that is your Down syndrome. So this Down syndrome shows the presence of typical mongoloid faces, where you have up slanting of eyebrows, guys, if you have a look. So the mouth is open. Why? Because the tongue is large. Here you have a brush fall spots in the iris, you have a single crease, that is the Siemens crease, Palmer crease, you have a sandal gap. And what is the most common leukemia in your Down syndrome? Overall, it's ALL, guys. And if someone asks you in less than 2 years, guys, that is your AML M7. Then this we have already done, guys. Then coming to the Patau syndrome, that is due to your trisomy chromosome 13. Edward was for 18, guys. Here you see the presence of polydactyly, cleft lip and cleft palate, very common, and coloboma of the iris, that is again important. Then this coming to the Edward syndrome, guys. Okay, so this is Edward syndrome, where you see the rocker bottom fate, guys, very important finding. Okay, and here in Edward syndrome, guys, horseshoe shaped kidneys are common, and here you may see congenital heart disease, overlapping of the disease. And this is your Turner syndrome, guys. Okay, Turner syndrome, which has 45 X, so means both X chromosomes are not there, so ovaries are not well developed. So this leads to the presence of streak ovaries, webbing of the neck, and also your heart defects would be present, guys. Okay, and there would be widely spaced nipples. So this was about your streak ovaries. This is a technique of fish, that is fluorescent in situ hybridization. So like for your PCR ka technique, for your CML ka diagnosis, chronic myeloid leukemia, this is used, guys. Okay, then guys, this is not so important. Then we'll read about your hypersensitivity ka mnemonic, guys. Okay, so first of all, we have four type of hypersensitivity. That is, the mnemonic is ACID: allergic, cytotoxic, immune, and your delayed hypersensitivity. So now coming on to the type 1, that is allergic wala. A for allergy, B for bronchial asthma, which is again due to allergy, IgE ka increase. C for Casini-test, that is done due to hydatitis, echinococcus. D for drugs, that is penicillin. Then coming to the type 2. Type 2 means my blood group is Rh positive, guys. This is the mnemonic for your type 2. Okay, so my means M for myasthenia gravis, that is HLA-B8, guys, if you can recall. Then blood transfusion reaction, guys. You can have, the most common is febrile non-hemolytic transfusion reaction within 6 hours, guys. This is important, guys. Febrile non-hemolytic, and also you have TRALI, transfusion related acute lung injury. Then G for Graves disease. This is again HLA-B8 positive, guys. Then good pasture disease. Do you guys know the mnemonic for good pasture? That is 1, 2, 3, 4, guys. Okay, so this good pasture is a type of type 1 RPGN. 2 means type 2 hypersensitivity. Type 3 and type 4 means antibodies against alpha 3 type of type 4 collagen. RH means RH incompatibility. I means immune thrombocytopenic purpura, immune hemolytic anemia, and insulin dependent diabetes mellitus. RH means rheumatic heart disease and RH incompatibility. Positive P means pemphigus and your pernicious anemia, that is HLA-B5 positive. Then coming to the type 3, the mnemonic is sharp. S for SLE, S for serum sickness, S for Schick test, which is used against diphtheria. Then HSP, that is Hinoz-Sonlin purpura, that is common in children. A for arthrus reaction. R for Raji-Zese, which is not done now. P for post-streptococcal glomerulonephritis, that occur 10 to 21 days after a sore throat infection. And PAN, that is polyarthritis nodosa. PAN does not involve the lungs, guys. P is not for P, be very sure. And 30% of the cases are HBsAg positive. Then coming to the type 4. So this type 4, guys, basically delayed hypersensitive wala, that is granuloma wala. So interferon gamma causes the granuloma. Vasculitis like temporal arteritis where you see granuloma. Contact dermatitis, guys, again very important. Suppose you like bindi can cause, that is due to paratertiary butylphenol. Now coming to SLE, guys. This SLE may be either due to type 3 or type 2 hypersensitivity. So, but more commonly we say type 3. Rheumatoid arthritis. Room has 4 walls, guys. So that was type 4. HLA-DR4 is also there. And this can be type 3 also. Hypersensitivity pneumonitis is again type 3 and type 4 both. Then transplant rejection, guys. If there is hyperacute or acute and chronic, guys. Acute means come time, chronic more time. That is 2 plus for you do. Hyperacute suddenly, guys. That is type 2, guys. Okay. So this was about your hypersensitivity ka mnemonics, guys. Okay. Now we are done with this hypersensitivity ka mnemonics part, and we are done with काफी सारे miscellaneous वाले parts, guys. Okay. So now let's get started with the next target, guys. That is your topic of upper limb, guys. Okay, so let's make the topic of upper limb simple. So first of all, you have the brachial plexus, guys. Okay, so this brachial plexus, we have roots, trunks, division, cords, and branches. Okay, roots, trunks, division, cord, and branches. This was about your brachial plexus. So see, you have C5 to T1. So this C5 and C6, this forms your upper trunk. Okay, this C7 forms your middle trunk, and this C8 and T1 forms your lower trunk. Okay, all of these trunks, guys. Okay, so all of these trunks divide into divisions, guys. Okay, so they divide into anterior division and your posterior division. So if you see anterior division of your upper and middle trunk, they unite to form your lateral cord. Anterior division of the middle trunk, okay, they continues as the medial cord. Then posterior division of all the three trunk, they form the posterior cord. Means posterior division, if you see, guys, all of them combined, guys. Okay, so that is your posterior cord. Do you see all of them, all the three combining? Now see, anterior division of the upper and the middle wala, they combine to form a lateral cord. And your anterior division of your middle trunk, Okay, so that continues as your medial cord. That was about your cord wala thing, guys. Okay, now coming on to branches from roots and trunks, guys. Okay, so if we talk about the roots, guys. Okay, so we have the dorsal scapular nerve, guys, and long thoracic or nerve of bell that supplies your serratus anterior. Then your upper trunk, guys. Okay, if we talk about the roots, then trunk. So trunk, you have the suprascapular nerve and nerve to subclavius that supplies the subclavius, guys. Okay, so see, first of all we'll see once, then we'll see what each of them, the nerves they supply and the function, guys, they'll do. Okay, so see, first of all we had three cord, that is posterior cord, lateral cord, and the medial cord, guys. Okay, so this posterior cord is formed by the union of the posterior division of all the means upper middle and lower wala thing. Okay, this lateral cord, this is formed due to the anterior division of the upper and the middle cord, and this medial wala cord. Okay, so this medial wala cord is formed due to the anterior division of the lower trunk, guys. Okay, so this is formed due to the anterior division of the lower trunk. I thought this the mistake was there. Okay, so this was about your roots, trunk, division, cord branches. Now coming on, guys, to what are the branches of posterior cord, lateral cord, medial cord, guys. Okay, so guys, don't medial, remember the mnemonic M for you. Okay, lateral, remember LML. Then your posterior cord, guys. Most of the books suggest the mnemonic, guys, ulnar, but you will get confused because ulnar nerve arises from your medial cord. So it's better to remember the mnemonic lunar, guys, so that you don't make any confusion, guys. Okay, so first of all, guys, you see here what you see, first of all, L means lower subscapular nerve, U means upper subscapular nerve, N means nerve to latissimus dorsi, guys. Okay, which causes winging of scapula, guys. Okay, serratus anterior, sorry, not serratus anterior, sorry, nerve to latissimus dorsi, guys, that is your thoracodorsal nerve, which supplies your latissimus dorsi, very important. Then A for your axillary nerve and R for your radial nerve, guys. Very, very important thing that you need to know. Then coming on to your lateral cord, LMN. L means lateral pectoral nerve, M means musculocutaneous nerve, which supplies three muscles, BBC, biceps brachialis. Okay, biceps brachii, brachialis, and your coracobrachialis. And L means lateral root of the median nerve. Do you see, guys, how this median nerve is made? This is formed by the lateral root of the median nerve and your medial root of the median nerve. Both of them combines to form your median nerve, guys. Okay. Then now someone asks you musculocutaneous nerve. Where does it arise, guys? LML. That is musculocutaneous arise from your lateral cord, guys. Okay. So you need to recall this mnemonic, guys. Ki what comes. Do not mix and match, guys. Otherwise, you will make the answer wrong. Then coming on to the medial cord, guys. Okay. If we see, this is the medial cord, guys. Okay. So what they give, that is M for you, 4M. Medial pectoral nerve, medial cutaneous nerve of arm, medial cutaneous nerve of forearm, and one is the median root of the median nerve, and the last one, that is your ulnar nerve. So the two things that are most frequently are this axillary nerve and the radial nerve. They are the branches of your posterior cord, guys. You must know, do not confuse it, guys. Okay, this is very important. Okay, and this A and R does not come under any other also, guys. Okay, if you see the mnemonic, so there is no chance of making mistake, guys. Okay, so this is must know thing about this. Okay, now coming on to the next one, guys. Okay, now we have talked about so many things. So see, dorsal scapular nerve. So this dorsal scapular nerve, that is C5, this supplies the rhomboids major, minor, and your levator scapulae, means the muscles which are there around the scapula. Okay, then supraspinatus. So this will go supraspinatus, infraspinatus. This supraspinatus has a work of abduction 0 to 15 degree. What is, guys, 15 to 90 degree? That is deltoid. And what is the nerve supply of deltoid? Your axillary nerve. Then nerve to subclavius, guys, supplies the subclavius. The long thoracic nerve, guys. Okay, so this long thoracic nerve, also known as, guys, nerve of Bell, guys. Okay, and this supplies your serratus anterior. And if there is a paralysis, this causes winging of scapula. Again, a very important thing that you need to know, guys. Okay, now moving on to the next one. That is coming to the lateral pectoral nerve, guys. Okay, so this lateral pectoral nerve. So this supplies your pectoralis major. And medial pectoral, remember M, guys, medial pectoral nerve. So M will say, I won't differentiate between both the M, means I'll supply major also, minor also, guys. But this lateral wala thing, they supply only the major thing. They say I won't supply the minor wala thing. M says I have M with me, so I'll I won't be partial to any M. Remember, recall like this, guys. Then this lateral pectoral nerve, they pierces the clavifactoral fascia. So let's complete here only, guys. What are the structures piercing the clavifactoral fascia? CALL is the mnemonic. C means cephalic vein. A means acromiothoracic artery. L means lateral pectoral nerve. L means lymphatic, guys. And this encloses the two muscles, guys. Okay, what are the two muscles which this clavifactoral fascia encloses? One is the subclavius muscle and one is the pectoralis minor muscle, guys. Okay, then coming on to the upper subscapular nerve, this supplies the subscapularis, the lower one, guys. Okay, this supplies not only subscapularis but also your teres major. A very important PYQs that you frequently confuse, guys. Okay, teres major is lower subscapular nerve, and teres minor, if someone asks you, that is your axillary nerve. Axillary nerve supplies deltoid and your teres minor. Thoracodorsal nerve, the nerve to latissimus dorsi, guys. Okay, so this latissimus dorsi is known as the swimmer's muscle, guys. Okay, again this may be asked in your exam. Now coming on to the next one, guys, that is a musculocutaneous nerve. So we said this supplies three things, that is CCB, BBC, guys, brachialis, biceps brachii and the coracobrachialis. Then the root value of the musculocutaneous, guys, C5, C6. Median nerve, guys, all the root value C5, C, because this came from medial root of the median nerve and the lateral root, guys. Okay, so they combine, guys, that is C5 to T1, guys. Okay, so this is important, guys. Then coming to ulnar nerve, guys, that is C7, C8 and T1, guys. Okay, so this ulnar nerve, they arise from your medial cord, ulnar nerve. Okay, so after arising, what was the mnemonic, guys? M for U, guys. Okay, that is your U for ulnar nerve. So this arises from the medial cord and they runs down, guys. Okay, and supply the thing. We'll be seeing what does it supply in arm, forearm and the hand, guys. Don't worry, I have made a table so that it becomes very easy for you. Then radial nerve, guys. Okay, that is C5, C6, C7, C8, occasionally T1, guys. Okay, that is important. Now see, we have summarized the root value of all the must know nerve, guys, that you don't make mistake in the exam. Okay, so musculocutaneous, that is C5, C6 and C7. Median nerve, C5 to T1, because it's a combination. Ulnar nerve, that is C7, C8 and T1, guys. Okay, then radial nerve, that is a C5 to T1 again. Axillary nerve is a C5 and C6, and thoracodorsal nerve, that is C6, C7, C8. Now coming on to the next one, guys, that is your guys, ups paralysis. This question is very pakka in your upcoming exams, guys. Either this will come or your clump case, guys. Like this is one of the most expected thing that repeats, like so many times this is repeated. Like see, when you see the upper trunk, guys, we had C5, C6, which gave anterior division and posterior division. Also here you had two things origin, that is your suprascapular nerve and your nerve to subclavius, guys. Okay, see, and if this region is injured, guys, that is known as your Erb's palsy, guys. Okay, so see, when this upper trunk is injured, guys, okay, axillary nerve, what was, guys, the C, that is C5 and C6, and musculocutaneous C5, C6 and C7, so both will go, guys. Okay, so when axillary nerve gone, axillary nerve supplies deltoid and teres minor. What was the work of deltoid, guys? 50 to 90 degree ka abduction, so that is lost, so the hand will come into adduction. Musculocutaneous supply coracobrachialis, brachialis and biceps brachii, guys. Okay, so when this is gone, guys, okay, so this is gone, so the elbow will be extended and pronated, hence the child appears like this, guys. This is important. So this is also known as waiter's tip or the policeman hand. Very important. See, you have adduction of the arm, you have the medial rotation and extension of the elbow plus the pronated forearm. This is important, guys. Okay, and this happens due to excess displacement in infants during a difficult delivery. So these are causes of your Erb's paralysis. Now coming on to the, see, Erb's wala is the upper wala paralysis. Remember, Erb's is the upper paralysis. If clump case, guys, okay, clumsy people looks down, okay, that is your lower ka paralysis, that is C8 and T1, due to birth injury in a breech delivery or a people holding a tree ka image would be given, guys. So this is very important, you know, clump case ka paralysis. Then coming on to your Horner syndrome, where you have sympathetic neuron ka problem, guys. Okay, so the mnemonic is ample. E for anhydrosis, that is your lack of sweating. M for meiosis, that is pinpoint constricted people. P means ptosis, that is drooping of eyelid. L means loss of ciliospinal reflex. And E means in ophthalmos. Again, important question, guys, that you need to know. Then coming on to the next one, guys. Okay, so this is a table which has summarized like the most common clinical sign that you see, guys. Okay, so this radial nerve C5 to T1, guys, radial nerve means drop will be there, guys. Okay, that is wrist drop is there. Median nerve, guys, that is your ape hand, guys. Okay, then ulnar nerve is your claw hand. Then long thoracic nerve, this causes winging of scapula and it supplies the serratus anterior. Then your suprascapular nerve supplies the supraspinatus. See, long thoracic nerve we already know, or the nerve long thoracic nerve that supplies your serratus anterior, guys. Okay, and winging of scapula is important here. Do you see the scapula becomes unduly prominent? This is only known as winging of scapula. And axillary nerve will cause loss of abduction. Why? Because it supplies deltoid. Deltoid goes from 15 to 90 degree, the major abduction, so it will be lost, and there would be regimental bias of anesthesia. Okay, so this was about this. Now see, this is one which shows about all the injury, guys. See, this we have already done. Palsy, upper paralysis, that is upper trunk. Clump case, that is lower trunk. Winging of scapula, that is long thoracic nerve. Okay, then axillary nerve ka injury, regimental badge sign. Ape hand, guys, is your median nerve ka thing. Okay, wrist drop is for radial nerve, and claw hand is for ulnar nerve. Again, very important, guys. Okay, so basically this only wrist, and they have tried to show with the help of images, guys. Anterior interosseous nerve, remember, guys, OK sign. This is important, guys. Kilonevin sign or the OK sign. This is very important. When there is a median nerve entrapment, guys, that can occur at the carpal tunnel syndrome. This is again important. Ulnar nerve will show few signs, guys. Okay, we'll be revising each of the signs in a form of flowchart, guys. Okay, so see, this is basically a flowchart, guys. Okay, which has given you all the muscles of the arm, forearm, guys, in the order, guys. Okay, so see, first of all, we'll come here slightly late, guys. Okay, before that, let's see this, guys. Okay, so that it becomes a bit easy for you, guys. See, first of all, we'll start with the forearm, guys. Okay, so this forearm has the presence of 8 muscles. Try to visualize, guys, so that it becomes easy for you, guys. Okay, so this forearm has 8 muscles. Okay, and these 8 muscles are split in the form of superficial and deep, guys. Okay, wait, I'll open the page for you so that you can see, guys. Okay, so they have superficial and deep muscle, guys. Do you see? So there are 5 superficial muscle and 3 deep muscle. If you can have a look, guys. Okay, that is your 5 superficial wala muscle and your 3 deep wala muscle. So what are the superficial muscle? First of them, it is pronator teres. Then it's flexor carpi radialis, guys. Try to extend your hand, guys, and try to see. First pronator teres, one which going slightly means at an angle. Then the lateral most part is the radial bone, so flexor carpi radialis. Then you are going to the palm, that is palmaris longus. Then you are going to the digits, that is flexor digitorum profundus. Then at the medial most end is your ulna, that is your flexor carpi ulnaris. Now coming on to the deep compartment. So you have a muscle, okay, which forms like a quadrate, guys, at the end of the radius and ulna, that is your pronator quadratus. Then the one which goes to the digit and lie at the deep, that is profunda, that is flexor digitorum profunda. And one for the movement of thumb, pollicis means thumb, that is your flexor pollicis longus. So this was about all of your 8 muscles that you see, guys. Okay, out of this 8 muscle, guys, remember 6.5 are supplied by the median nerve and only 1.5 are supplied by the ulnar nerve. So it's better to remember 1.5 so that you remember other things, guys. Okay, so this 1.5, first the name which comes ulna comes, that is flexor carpi ulnaris. Towards the ulnar side, ulnar nerve will be there, guys. Okay, also we had one more, guys, that was flexor digitorum profundus, a big muscle that is supplying the digits, guys. Okay, when it's supplying the digits, so it will be medially and laterally, guys. So what is medially, guys? Medially you have your ulnar nerve because ulnar lies medial, guys. Okay, so that is your medial half of your flexor digitorum profundus, guys, would be supplied by your ulnar nerve, guys. Okay, so this was about your forearm ka supply, guys. I think you are clear now. 1.5 by the ulnar nerve, guys. Okay, that is 1.5 means first one is the flexor carpi ulnaris and remaining half means medially ulnar lies, that is medial half of flexor digitorum profundus. Now moving on to the extensor wala thing, guys. Don't recall, guys, everything is supplied by radial now. Just know this and leave it off, guys. No need to remember, guys. You cannot remember so much. Okay, now coming on to the hand, guys. Okay, I remember my first year, guys, where when ma'am told that 20 muscles in the hand, I was damn shocked how to remember, guys, this 20 muscles. But it's very easy, guys. Till now, there what happened? Only 1.5 was supplied by. There what happened, guys? 1.5 was supplied by your ulnar nerve, guys. So Bhagwan will be like, no, I should not be so unfair. So this here 1.5 suddenly becomes 10 times. That is 15 muscles are supplied by your ulnar nerve, and this median supplies only your 5 muscle, guys. Okay, so now think, guys, ulnar nerve was on the medial side, means this ulnar nerve was on the medial side. So this median nerve will be on the lateral side, guys. And lateral side, what is there, guys? Okay, see, this is your lateral side. If I talk, guys, that is your thumb wala side. So it will supply the muscles of the thenar eminence, that is thumb ka eminence, guys. So what are the three things it supplies? Remember the mnemonic AFO: abductor pollicis brevis, flexor pollicis brevis, and O means opponent's pollicis. Okay, then two more muscles, guys. So we have the presence of lumbricals, guys, 4 lumbricals. Okay, so the first and second lumbricals means the lateral 2 lumbricals, you can remember like this. Okay, so that is 2 lateral lumbrical, that is due to your median nerve. That is 5 done. So remaining 15, guys. So now let's name the 15. First of all, we have 4 hypothenar muscle like AFO: abductor digiti minimi, flexor digiti minimi, opponents digiti minimi, and P is for palmaris, 1 P is for palmaris brevis. Do you see, guys, this 4 hypothenar muscle? Three thenar done. So fourth is not done. That is adductor pollicis will be supplied by your ulnar nerve, and this is a PYQ. This adductor pollicis, this is known as the graveyard of the ulnar nerve. The ulnar nerve ends here. Again, important thing. Then your palmar muscles. So we have lumbricals, guys. So 2 and 2 lumbricals. 2 supplied by your median, 2 by your ulnar. Dorsal interossei, palmar interossei, guys. All the interossei where the dorsal or palmar are supplied by your ulnar nerve, guys. That makes to the 15. 4 plus 4 8 plus 4 12 plus 2 14 plus 1, guys, 15. I think this is done. Remember the mnemonic palmar is adduction, means add karna, that is bringing it close, guys, is your adduction. Abduction, making it far, guys, that is the abduction, guys. This is important that you need to know. Okay, this is again important that you know. See, I have made this lumbricals wala thing. Okay, so how to remember the action of lumbricals, guys? Okay, so try to, like the Kapil Sharma. So if you might have seen that Babaji ka Tullu wala type. Okay, so try to make a L, okay, with your hand. So when you make a L with your hand, guys, okay, like this, if you make a L with your hand, so what happens, guys? At the metacarpophalangeal joint, guys, there is a flexion and there is extension at the interphalangeal joint. So that is basically your action of lumbricals, guys. So we have 4 lumbricals: L1, L2, L3, L4. L1 and L2, that is lateral wala 2, guys. Okay, so that is supplied by your median nerve, and medial 2 is supplied by your ulnar nerve. This L1 and L2, guys, they are your unipinnate thing. Okay, means one head is there, one belly is there, and this L3 and L4 are the bipinnate thing. This function we have already done, guys. You can look at this. Okay, try to make a finger like this, guys, so that this does not become tough to remember, guys. Okay, so this becomes easy now, guys, if you make a finger like this. Then coming on to the interossei, guys, we have 4 palmar interossei, 4 dorsal interossei. Palmar, the mnemonic is pat, that is adduction. Dorsal is dab, that is abduction. Okay, so see, this palmar is tested by your card test, guys, again important, and this dorsal is tested by your Igawa's test, and all of this interossei are supplied by, guys, that is your ulnar nerve. Means this test, like your card test, your Igawa's test, book test, Foreman test, all of them are the test for your ulnar nerve. Very easy now. Okay, so see, this is basically a summary of entire supply, guys. See, median nerve, I said, guys. Okay, see, 6.5 thing is supplied by your median nerve. Okay, and ulnar nerve is 1.5 thing. Okay, now, so see, that is your 6.5. So first we had in superficial compartment 5 muscle, guys. So 4 come here, 5th one is here, guys. Okay, deep we had 3 muscles, guys. Okay, so this profundus is half and half, guys. Okay, and this deep part of the median nerve is known as the anterior interosseous nerve, which shows the presence of okay sign. Again important, guys. Okay, hand, guys, we had 5 muscles which is supplied by your median nerve, and the remaining 15 is supplied by your ulnar nerve, guys. Okay, see, 1 thenar, because 3 had already been supplied here, and first and second lumbricals, guys. Okay, so this is about your nerve supply. So now coming on to this one, guys. Okay, to know that to know the test that you need to know. So first of all, ulnar nerve, guys. Okay, remember like a C, B, C, D means dorsal interossei, you can remember. E for Igawa's test, F for Foreman sign, guys. I think it's done now. I think no confusion. Okay, now we'll see the images also, don't worry guys. Then coming to the median nerve guys, median nerve, everything like P is coming, ape thumb, pin test, pincer grasp test, pointing index test, that is pop benediction hand, everything is like coming with P. Then radial nerve causes the wrist drop, finger drop, well, thing. Okay, so this is important. Now see, we'll start with nerves one by one guys. Okay, we won't go in very detail about the course guys because it's not a theory paper, but we'll see the important thing that you need to know before going for the exam guys. Okay, so see, axillary nerve, this axillary nerve guys, they arise from the posterior cord. The mnemonic was guys, if you can remember, the mnemonic was lunar guys. Okay, A for axillary nerve and R for radial nerve guys. Okay, so how does this axillary nerve after coming out guys? Okay, this, there is a space guys, this is the space that is known as your, see, this is made with the two fingers. It's very easy guys, try to make like this with your fingers guys. Okay, so this space that you see is your quadrangular space, this is your upper triangular space, and this space is your lower triangular space guys. Okay, this is very important. So see, basically what happens here, so this is the humerus guys. Okay, this one is your teres major, this one is your teres minor. Okay, this one is your humerus ka shaft, and this one is your triceps ka muscle. Okay, triceps muscle. So what are the things that comes here guys? Okay, if you see this quadrangular space, contents you need to know. Quadrangular space, the content is axillary nerve and posterior circumflex humeral artery that winds around the humerus guys. Okay, because humerus is close by, you can think guys, humerus is so close by here. Okay, then triangular space guys, so this triangular space contains scapular circumflex artery, and this triangular interval, this is also known as triangular interval or the lower triangular space guys, that is your profunda brachii artery plus the radial nerve. Again important guys. And axillary nerve, what happen if there is a paralysis? There is the impaired abduction. Why? Because 15 to 90 degree movement is lost, and there is a loss of shoulder counter. Teres minor will also be affected. Why? Because the axillary nerve supplies deltoid and the teres minor, and there would be regimental badge of anesthesia and loss of sensation around the deltoid muscle, because that is the sensory supply of the axillary nerve. Very easy guys. This is common in your fracture of the surgical neck of the humerus, dislocation of the shoulder joint. So these are the reason where you see axillary nerve ka injury. Now coming to your ulnar nerve guys. Okay, this ulnar nerve is also known as your musician nerve guys. Okay, because it controls the fine movement. Do you know guys how many muscles are supplied in the hand? That is a 15 muscles guys. You can think guys, out of 20 muscle, 15 is supplied by ulnar nerve. So all the like fine movement that would be tuned by your ulnar nerve. So like playing a music requires your fine coordination, so that is your musician nerve. So this ulnar nerve arises from the medial cord, that is M4U was your mnemonic guys. Okay, so see, we won't read guys entire pathway guys, but the thing that you need to know guys, in the arm it does not give any branch. In the forearm guys, ulnar nerve supplies 1.5. Can you recall for me? One is the flexor carpi ulnaris and one is the medial half of flexor digitorum profundus guys. Okay, then your 15 muscles in your hand guys, that is supplying guys. Okay, so basically this is important, this passes behind the medial condyle of the humerus guys. Okay, so what happens, this ulnar nerve guys comes in the axillary and arm guys, this pierces the medial intermuscular septum located medially guys. Okay, then it goes behind the lateral condyle of the humerus guys, and then it comes forward guys. Okay, basically then it enters the anterior compartment of the arm. So this is important here. Okay, see, then what is the cutaneous supply of this ulnar nerve guys? Okay, so this ulnar nerve, basically this lies medially, so this supplies the medial 1.5 digits guys. This is again important. Then branches of the deep terminal branch guys. Okay, and see, this we have already read about the 15 muscles that it supplies. It also supplies your carpal joint. This ulnar nerve can get trapped in your Guyon's canal, U for ulnar, remember. And one thing, the important thing is your ulnar paradox, means if the lesion is lower down guys, okay, that is more severe. The ulnar nerve causes claw hand guys, more severe is the claw. If the lesion is higher up guys, claw is less severe. Why? Because when you have higher up guys, like both like flexor wala compartment is affected guys, so that is the reason. Then seeing the test guys. Okay, so remember B first of all, B for book test, C means card test, D for dorsal introversia, E for Igawa test, F for Fomin test guys. Okay, see, this is the normal thing, but what happens when it is paralyzed, you try to use the thumb ka muscle guys. Okay, so that is your Fomin sign, because this flexor pollicis that is supplied by your median nerve guys. Okay, so that is your book test. C for card test, guys. We know palmar interosseous, PAD, adduct means bring it close, guys. Okay, so we try to ask him to hold it close, guys. Okay, if he's able to hold it, fine. So this will detect ulnar nerve function. Then dorsal interosseous, dab, abduct. So against the resistance, will ask to move it away. Then your ulnar nerve, which causes your claw hand, guys. This is done. Okay, then coming to the median nerve. So 15 muscles already supplied. Now the 5 muscle. So we have talked about the fine movement, but coarse movement also our body does. So that is your by the median nerve. So it's known as the labral nerve. This is formed by the lateral and the median nerve from the cords, guys. Okay, this what happens to the median nerve, guys? Okay, so this median nerve basically passes between the two head of the pronator teres wala thing, guys. This is important. Okay, to enter the front of the forearm. So this can get compressed over there. Also there is a struthus ligament where it may get compressed. See, all of the things is there where you have P wala thing, ape hand deformity, ape thumb deformity, guys. Okay, this is important. See, this injury, this median nerve injury is common in your fractures wala thing like supracondylar fracture, again very important. Now see, we'll see some of the important thing, guys. Okay, so this can compress here at the between the two head of pronator teres, known as the pronator syndrome. I struthus ligament, that is the anatomical variant, here also it can get trapped, guys. Okay, and this is known as the carpal tunnel syndrome if it gets trapped at the wrist, guys. Okay, so there will be pain and tingling and the numbness sensation around the area of the distribution of the median nerve. So ulnar nerve, I already said, guys, this supplied the 1.5 middle wala thing. So do you see, guys, the lateral 3.5 wala thing is supplied by your median nerve, guys. Okay, so there is a burning pain in the lateral 3.5 digits in the night. So what are the signs, guys? This shows the Phelan's test, the Tinel sign, and symptoms of pain, paresthesia and anesthesia, guys. This carpal tunnel syndrome is the most common compressive neuropathy, guys, and the most specific test is the Durkin test. Also we have Tinel test and the tapping test, guys. This looks like, see, do you see there is a wasting of the thin arc eminence because that is supplied by your median nerve. This is your ape thumb deformity, guys. If you see thin arm muscle ka atrophy is there, guys. This is your pen test. Do you see P is coming, guys? Everywhere P is coming. This is your Osner's clap. Benedict B looks like P, pointing index sign, pop sign, and this OK sign is anterior interosseous nerve. That is a part of your nerve. Okay, now see, these are the ulnar nerve, guys. Okay, ulnar nerve, guys, C8, T1, axilla, I said no branch, upper arm, no branch, just to the elbow joint, guys. Now ulnar nerve will give 1.5 supply, guys. Okay, see, let's see, does it give 1.5? Flexor carpi ulnaris, flexor digitorum ka medial half, guys. Then it won't give some cutaneous branch and see. Now see, this is giving the 15 muscle branch. So it's done. Now coming on to your radial nerve, guys. Okay, so this radial nerve C5 to T1, guys. Okay, so this radial nerve gives basically here the posterior cutaneous nerve of the arm in the axilla. Also the triceps ko it will supply there in the arm, guys. Brachialis by brachioradialis, also brachialis is a hybrid muscle, guys. It's supplied by both radial nerve and your musculocutaneous nerve, guys. And here all the extensor compartment that you don't need to know, guys. Okay, now coming to the radial nerve, guys. Axilla, we said about the long and the medial head it supplies in the axilla. In the spiral groove, guys, so this is common to be trapped in fracture. They supply the lateral and the medial head and the anconeus. And close to the lateral epicondyle, guys, it supplies brachioradialis, under which the superficial radial nerve, extensor carpi radialis longus and the brachialis, guys. Okay, so this is important here, guys. Okay, now see, example in your crutch palsy, guys. Okay, so there it is a compression at the axilla, so everything will be affected, guys. Saturday night palsy, after coming from a party you slept like this by mistake, so there is a compression, guys. So there would be wrist drop, finger drop, sensory loss because it is very higher up. This is a radial group ka fracture, Holston Lewis fracture, again injury at the spiral wala thing. Okay, then you can have other fractures where it may be affected, guys. Okay, now seeing the claw hand, guys. We have partial claw hand, complete claw hand. Claw hand was due to ulnar nerve, guys. Okay, so that was claw hand. So what is the treatment used, guys? That is your knuckle bender splint is used. Complete claw hand when you have both ulnar and the median nerve, guys. Why? Because ulnar is supplying the medial too, guys, and median is supplying the lateral too. That is important. Wrist drop use a cock up splint, guys, again important. Foot drop is due to common peroneal nerve injury, again very important. Foot drop splint is used. Okay, and most common nerve injured in lithotomy position is again your common peroneal nerve, again important, guys, that you need to know. So so this was all for today, guys. I think hope you learned something new. If you like it guys, please do comment, like, share and subscribe. Do comment if you want me to add any specific topics for your upcoming exam, any topic that you want to to revise guys. Please do comment, like, share and subscribe with your subscribe and share with your friend. Happy learning guys.